You're listening to Gender, a Wider Lens.
I'm Stella O'Malley, a psychotherapist in Ireland.
And I'm Sasha Ayad, an adolescent therapist in the United States. Since 2016, my practice has been exclusively dedicated to gender questioning teens and families impacted by gender dysphoria.
I also work with gender questioning teenagers, and I facilitated support meetings for families and individuals who've been impacted by gender issues.
We're curious about the concept of gender and how it's unfolding in the wider culture.
Join us as we look at gender through a wider lens.
Dr. David Bell retired last year from his position as a consultant psychiatrist at the Tavistock and Portman NHS Foundation Trust, where he worked for 25 years. He's also the former president of the British Psychoanalytic Society. While he was in the governor role at the Tavistock, through a series of events which we covered today, Dr. Bell discovered that something was going terribly wrong in the Children's Gender Identity Development Service, or GIDS. Something I didn't know before speaking to Dave is that the broader Tavistock Service had an established reputation for excellent psychotherapeutic treatment. So, clinicians who applied to work there were expecting to join the ranks of the most thoughtful and knowledgeable psychotherapists in the UK. Those young and inexperienced clinicians who happened to get funneled into GIDS landed in a very different kind of treatment setting. They started raising their complaints and getting nowhere, so they started to trickle in one by one to tell Dr. Bell their stories. Not only were they feeling ill-equipped to provide proper, thorough care to kids with very complicated backstories, but they were also getting a clear message from their direct chain of command. Concerns were not going to be properly addressed, and in fact, there was a culture of fear about raising these issues, and clinicians felt a very strong pressure to simply get through their humongous caseloads without rocking the boat. In 2018, Dr. Bell described all of this in a highly critical report on the GIDS, which became part of a chain of events, including some critical involvement from our former podcast guests, Marcus and Sue Evans, which led to the judicial review, that's the Kiera Bell case, then the thorough external CAS review, and the CAS review's recent decision to close down the GIDS. So please settle in for this incredible episode with Dr. David Bell. Hi, Stella. How are you today?
I'm very well. How are you, Sasha?
I'm great. We're so happy to have Dave Bell on our program. Welcome to the show.
Thanks.
So where do we begin, Dave? What first got you into psychiatry, psychology, this whole field?
Well, that would be a long story that would take a great deal of time, and it depends, how deep you want to go. But I qualified as a doctor in 1973. That's a long time ago. And during my psychiatric training, I was very interested, during my medical training, rather, I was very interested in psychiatry. But once I did psychiatry, it put me off because it was very highly medicalized. It was very much to do with the idea that psychiatric disorders are brain disorders, and very little interest in the psychology of the person. So it put me off, and I got rather involved in anti-psychiatry. I read the works of Lang and various others. But then somewhat later, after I'd traveled abroad, I went to work in Africa for a few years after I qualified. I came back and I worked in a psychiatric hospital. And it was one of those old-fashioned asylums on the South Coast. And the consultant who I had there just was very pleased if I wanted to talk to the patients. So I started just talking to patients, and I got very, very interested again. And then I went to the Maudsley Hospital, where I trained as a psychiatrist. And whilst I was there, I met a consultant who was a psychoanalyst called Murray Jackson, who was very interested in understanding people with psychosis. And I saw him interview a patient, and my life changed, because he was able to bring a patient down from a delusional state and get them to talk about what was really upsetting them and worrying them. And seeing that transformation, I realized that's what I want to do. So then I started to train as a psychotherapist, and then as a psychoanalyst, and I remained interested in very complex and ongoing and difficult cases. I've never been convinced by the biological account of psychiatry, and I've never been convinced that psychotropic medication is helpful. And there's a lot of evidence now coming out from UCL, from the Critical Psychiatry Unit, to support that position. So then I trained as a psychoanalyst, and at the end of my training, I worked at a hospital, which was a therapeutic community called the Caseload. So I got my first consultant job there, and there I got very interested, of course, in institutions and group dynamics, and which they were very interested in there. But I also worked with very, very seriously disturbed patients. I then came to the Tavistock and was appointed as a consultant there, and some years after I was appointed, I became. I founded and I created a unit for providing psychotherapy for very seriously disturbed patients who had complex and enduring problems over much of their lives. Many psychiatric patients, if you really ask them, you'll find they've been disturbed since they were at least adolescent. This idea that suddenly they've got an acute depression rather evaporates if you talk to people. So I founded that unit, and it was very successful. And we used to see patients for a number of years in individual and group psychotherapy. And it was in that context, in the Tavistock, where I became a governor of the trust.
And when did you become a governor, and were you involved with the gender identity development services?
Well, it might be helpful for people to understand what a governor is first.
I was going to ask, as the American in the bunch here.
Yeah.
Okay,
well, a governor is a kind of parallel system of governance that all NHS trusts have. And it's a body that consists of staff from the trust, but also people from the community, so people representing, in our case, Camden and Islington, Camden, Islington, London, rest of London, and rest of England. So a number of people who are representing the community that we serve. And then there was a trade union representative. There were representatives of other, what we might call stakeholders. And then there were staff representatives. And there were 3 staff representatives. One was trade union representative. One was admin and technical. And I was the, sort of called at the time, senior clinical, but I think the senior was unnecessary. So I was a clinical and academic staff representative. And I served 2 terms. So each term was 3 years. I served my first term probably about, about 2012, something like that. And then I served a second term. And that second term was from about 2016, I would guess. I'm guessing a bit, but that gives you a rough idea. To about 2000, must have been 2015 to 2018. And it was in that, and I had no connection with the gender service. I was working in the adult department. But I was very concerned even then about the gender service, because it seemed to me there was a very glossy, rather idealized version going round, but I didn't really understand what it was that they did. And I also picked up a sense in which people didn't want to discuss it. So at one point we tried to have a scientific meeting in which we might have some discussion and invite someone else to come and talk to us who had been thinking about it a long time, but had a different view. And I thought, rather naively, that we could have a little bit of discussion and debate. And I was told that wasn't right, that we didn't need to have anyone come into the trust to discuss this who wasn't a member, who wasn't already on the GIDS service. So there was obviously a lot of anxiety about debating about this. And I raised it many times within the trust about trying to have a meeting or find out more. And people were interested, but somehow, and this is not blaming anyone, this is a very typical institutional dynamic, it never quite happened. So I was concerned. I think I had a reputation in the trust for being one of the very senior clinicians, because I'd been there for a long time. By that time, I'd been there over 20 years. And I was also a former president of the British Psychoanalytic Society. So I was sort of known for being committed to the mission values of the trust, particularly psychoanalytic values. And I think that's why people approach me.
Can I ask a question, a broader question about the Tavistock at the time? You described yourself as always having been quite skeptical of the biological basis for psychiatric disorders. Aside from the GIDS service, was the Tavistock kind of operating in line with your philosophy of taking more of this kind of depth psychoanalytical perspective?
No, completely. That's why I was happy there. The Tavistock is basically known for three things: psychoanalysis, so a psychoanalytic attitude to psychological suffering. Child psychotherapy is a very major part of the Tavistock as well. And then an interest in families, both from an analytic and from a systemic point of view, and an interest in institutions. But all these have in common the idea that whatever is manifest is only a manifestation. And underneath it, there are deeper processes that it takes time to understand. So, of course, at the level of individuals, it's what's not so conscious, and understanding whatever symptoms present as being a compromise between the need to address something and also the terror and fear of addressing things that are deeper. So the Tavistock, 100%, we didn't prescribe at all. We weren't opposed to prescribing. We wouldn't have stopped patients taking tablets or whatever if they felt they're helping, but it wasn't part of what we did.
Okay. That's very helpful, and that really creates the contrast, the juxtaposition against what you started noticing about asking questions about the GIDS service and this kind of magical theory that they had. So pick it up from there. So you realize that there's really not a lot of debate. And then also, just as the institution chugs along, there just happened to not be any further meetings. Am I getting the story right? No debate.
There was no debate and no discussion, and very little interest in exploring it more openly, apart from, in a funny kind of way, just affirming what was going on. So what happened was that perhaps, I don't really know, but perhaps because of people knowing a little bit about me, I was approached originally by one person who was a senior therapist at GIDS. And that person was a child psychotherapist. And that person, I'm being sort of cautious because I have to keep things slightly anonymous. So he approached me and raised very, very serious worries about the GIDS service. After he approached me, another person approached me, and then another, and then another, and then another, until in the end, 10 people came to see me, which amounted to just over a third of the total staff of the London-based service. I say London-based because there was also a service in Leeds, which at that time I had no contact with. And I interviewed them all. And one of the things I first noticed was that none of them, except for one, wanted to come and see me in my room at the Tavistock. They're all frightened. If they were seen coming into my office, they might suffer in some way. The managers might say, "What were you talking to David Bell about? What are you up to?" So they came and saw me privately in my consulting room.
And presumably they don't know that each other is talking to you because of this kind of secrecy. Oh, they did
met them individually. And what happened was that, I met the first person, and he must have told the others. I had a very helpful conversation with Dave.
Okay.
So they did know.
Once they realized you were sympathetic,
I met them, more than one person at a time.
So they realized you were sympathetic and then started to come to you.
Yes.
Okay. Sorry, keep going.
So then they came to me. And,
could I ask, did they had they approached others, or were you the first and only person?
That's a very important question. I mean, they had. They'd approached their immediate managers. They'd approached the head of the service. They'd approached the medical. Not all of them had approached all these people, but these are all the people who've been approached. They'd approached the child safeguarding lead for the trust, Sonia Appleby. She'd been approached, and she was independently inquiring into the situation. And they'd also approached the trust Speak Up champion, who'd taken no action at all. Speak Up champion is a person who's supposed to protect people who want to make complaints or raise concerns so they can freely raise their concerns. The Speak Up champion had been approached about this. So they had, it's very important you say that, because sometimes people think, well, what are they doing coming straight to me without approaching their, taking the appropriate, approaching the appropriate people. But the other thing was that they were very frightened of talking to people. So they had raised these things, but they soon got the message. For instance, one of the therapists who spoke to me was gay, and he was a gay man, and he was very, very concerned about a child who he thought was gay or struggling with the feelings of being homosexual, and that this wasn't being addressed. But when he raised this, he was taken off the case. And he was also told he was an angry gay man. Of course, he no longer works for the organisation. So they were very frightened. So although they had tried to approach, they probably approached and then realised that there was a message, that we're seeing you as transphobic. So they didn't want to discuss it anymore.
And what sort of time frame was this? I'm kind of thinking, I wonder, did the first person approach the first, I'm only guessing, and who knows, the first person who's effectively blowing the whistle, approaching the first line manager, would that be 2015, 2016? And then by the time they came to you, it was a few years later. Yeah.
I couldn't say. They approached me in, I think my report was 2018. So they approached me, I think, between about January, something like that, or November, and summer. So between November 2017 and summer 2018, because I wrote my report in 2018.
It's funny, I was doing my film in London in 2018, Trans Kids, It's Time to Talk, and we wanted to interview the Tavistock. And we wanted to interview Polly Carmichael and other people from it. And we went to great lengths to get interviews from the Tavistock. And, in fairness, they said, whatever we say will be weaponized. But everywhere we went, we heard the Tavistock is in disarray. The Tavistock is in disarray. And we didn't know anything other than that's what everybody was telling us. And we never got the interview, which is life. And so take it from there.
Do you want me to tell you about the concerns that they raised?
Yeah.
Because there were so many, it would take up the rest of the meeting. But
oh my God.
They were very similar, the concerns that they raised. And this is what I interviewed them. I took notes on all the interviews, and then I put that into a report. But, just to go through some of them, I won't be able to go through all of them.
Right, just a few.
Yes. Well, the first one was the caseload. As you know, the service has increased from being, between 50 and 100 to being 2,700. So the whole service was under huge pressure to push these cases through.
Did you say there was about 30, 35? Did you say there was about 30 or 35 clinicians or something that were running it, and they were covering 2,000?
I can't remember. I don't know the exact number. I just know I was told that the number that come to me was somewhere between a quarter and a third.
Wow. That's phenomenal. Sorry, keep going.
So the first thing was that the caseload. So they had caseloads of up to 140 cases. 140 cases. So one of the clinicians I remember very well saying to me, she was a family therapist, and she said, she could think of, a different service that she worked in, and if there was a family, say 5 years ago, and you said something about the family, she wouldn't remember. But if you said, oh, it was the one where the father died quite suddenly in a car accident, and she'd be able to unpack who was in the family, what the problems were. That's the way it does. She said these cases, she couldn't remember anything about any of them because, first of all, it was unmanageable to have that number of cases. Secondly, a lot of them had the same story because they were scripted. That is, they'd gone online, they'd learned a script, they knew what to say in order to get the right diagnosis, because they were coming not to address their mental health problems, but to get the ticket to puberty blockers. That's what they were coming for, because the service was a gateway to medical treatment. So this therapist was saying he couldn't possibly remember the cases because they were all the same in terms of what they said, and he didn't have sufficient time to get past that before having to deal with another case. The second thing was that they raised concerns about consent. They thought consent was being handled very badly, and that the children weren't really having any idea of what the long-term implications were of what they were being involved in. The third thing was that the service was we call an affirmation service. That is, if a child came with what we now call gender dysphoria, and they would obviously say, I'm trans, they were immediately affirmed without further thought. And we all, many of us think that's a totally inappropriate clinical stance to take towards a patient. They thought that these kids, had complicated, often long-term difficult problems, but it was very difficult to get near those problems because there wasn't sufficient time, and they didn't think there was sufficient interest in the service to get to grips with these problems, which would take time. You'd have to build up a relationship of trust, and you'd have to get past the script. They thought that many of these kids suffered from other problems, such as trauma in the family, autism. We know that up to 35% are on the autistic spectrum. The others, a very substantial number, suffered from what we call internalized homophobia. That is, they recognized, say it's a girl, she recognizes that she feels attracted to girls, feels disgust about that, and may even have the thought, maybe I'm not a girl. Many lesbian girls feel that in the part of their development. But of course, now that this was possible, to think maybe I really am a girl, this was regarded as a way out of being gay, out of being a lesbian girl, or out of being so confused about who they were or what it meant. So they were also a very, very substantial number. And one of the clinicians described them as the most complex and difficult cases they'd ever dealt with. I think that one wasn't necessarily a judgment on the degree of mental disorder, but how difficult it was given the cultural support and the support of the service for affirmation. And the model was to see them for 4 to 6 sessions spaced out over many months. So you couldn't really form a therapeutic alliance. But some of them, I was informed, were seen substantially less and occasionally only once, and then referred for puberty blockers. So maybe that's some of the concerns that were raised. But the interesting thing was they all raised rather, similar concerns. They also, there were very inexperienced staff seeing these cases. So there are people who had only just completed their clinical psychology training, certainly had not, had the experience of working over long periods with disturbed children. They also complained that there's an anti-psychotherapy atmosphere. Like if one talked about, I think the senior therapists managed better, but the ones who were junior were interested in psychotherapy said they were mocked. They were told, oh, don't give us all that talk about the unconscious, or that talk about, all that psychotherapy babble. And they thought they'd come to the Tavistock for that reason.
We hope you're enjoying this episode of our podcast. We work very hard to maintain high-quality content for this show, and we're grateful to Rhyme and GenSpect for supporting us.
Rhyme, or Rethink Identity Medicine Ethics, is a non-profit organisation dedicated to improving long-term care for gender-variant individuals. Visit rethinkime.org to learn more.
And GenSpect is an international alliance of parents and professional groups whose aim is to advocate for parents of gender-questioning children and young people.
If you'd like to become a patron, you'll have access to weekly transcripts and special Q&As, and you can join our listener community.
Now back to the show. Yeah, that's so pernicious because, as you said, that's why people were attracted to the Tavistock. And I hear that line of thinking a lot, both inside and outside the gender world. I mean, I think all of the depth orientations have gotten a very bad reputation, and I'm not exactly sure why, but were these clinicians, the young and experienced clinicians, were they being kind of explicitly trained on this affirmation model? Or do you think it was more of just unspoken messages that they got about trying to dig a little bit deeper or, of course, the lack of time? Or was it an explicit, like, this is the affirmation model, this is what we use with gender?
One of the things they complained about was that there was no model. They didn't feel they're ever taught a clinical model. So there wasn't a theory, so they didn't really understand what it was they were doing. But they picked up that what they were supposed to do was affirm. I mean, the other things they complained about were that as part of this was the inappropriate influence of campaigning ideological organizations which had strong connections with GIDS, such as Mermaids and another organization called Gendered Intelligence. And one of the directors of the service worked for one of these organizations. So they were very deeply involved. So the whole service was very drawn in to this, a very, what we would now, of course, think of as a very extreme position as regards how to treat these children. And certainly they were very, those services like Mermaids and so on, they're very opposed to sort of trying to understand what was going on. They saw that as digging around and, not affirming the child. So that was, another major problem. Also, some of them were very concerned about the way the parents were treated. If the parents didn't agree, they were isolated and alienated from the service. And they thought, God, we need the parents there to tell us what's been going on in this child's life. But if the parents weren't automatically agreeing, they were often completely left out of the clinical discussion. And of course, there were a group of parents around about the same time who complained to the trust about this.
And when you wrote the report, where did the report go? And I guess, what was the outcome of that?
Well, I wrote my report. I contacted the chairman of the board and the chief executive. And I told them before that summer that I'd had these concerns raised that really worried me. And I was going to write a report. And they said that's fine. However, at the end of that summer, when they saw the report, they tried to stop me from sending it to the governors. And at that time, I was threatened that, the implication was that if I pursued with showing this to the governors, there were certain matters, it was a bit vague, that they might be able, certain kind of actions they might be able to take against me. But that was the first time where I took legal advice. And the legal advice was very clear that it was my role as a governor to send this report to the governors. And if I didn't, in fact, I would be reneging on my responsibility. So I overrode the threat and sent the report to the governors anyway. And of course, I sent it to the board. That summer was just when I was coming to the end of my term as a governor. So I was at a meeting where my report was briefly discussed. That wasn't wrong, because such a big report could not really be discussed in one meeting. So the decision was to set up a review of the service to be run by the medical director and one or two others who I don't remember, but including a representative from the governors. So that's what happened. A review was carried out about the service. I tried to find out about the review because I was very concerned that the people who had complained to me were not being interviewed because they would need to have guaranteed anonymity to be interviewed. So I did my best to find out what the terms of reference are told, but I was told I was no longer to be involved in this. But of course, I did find out things from talking to people. Eventually, the review was brought to the board and to the governors. Dinesh Sinha, their medical director, was responsible for that. But it wasn't really a proper review because all it did was talk to people. The review didn't say how many patients come to the service, what's the outcome for those patients, how many get this, how many get that, what's the follow-up. And that's partly because, again, one of the things that was complained about, there was no follow-up. No one knew what happened to these children. All the clinicians I spoke to regarded it as an experimental treatment, which it was. And there was no follow-up. No one knew what happened. And a lot of the kids who reached 17 went to the adult service anyway, and we don't know what happened to them. So, sorry, I've lost my. Oh yes.
So the review is done, I guess, by somebody at the
GIDS. Review was merely based upon talking to people, and of course, the majority of people who he talked to said what a good service it was, and then he talked to a few who didn't agree with that.
But who was in charge of the review? Can you just clarify
the medical director
of the GIDS?
No, the medical director of the trust.
Of the trust. Okay, go ahead.
So that review was a very poor review, and in essence, although it did raise some criticisms, the chairman of the board and the chief executive considered it as a kind of exoneration of GIDS.
Mm-hmm.
And at that time, I was no longer a member of the governors. So, but Marcus Evans was. Now, Marcus Evans had worked in the trust for many, many years, probably as long as me, but he'd retired, ordinarily retired from the trust. But he was on the governors as one of the other kinds of stakeholders, as being a member of the community that the trust serves. So he was Rest of London. And he was also very, very concerned, also because his wife, Sue Evans, had worked on GIDS many, many years before, and she had raised similar concerns many years ago. Also, we found, by the by, that the medical director, David Taylor, I think in 2010 or earlier, had raised serious concerns which were not noted. And also in 2015, an external consultant was asked to look at the service. And that external consultant said that the service should immediately put a cap on referrals because they weren't managing the numbers. But that again was ignored. So Marcus knew of all these things. And when the review was discussed in the governors, he was very, very concerned about the review not addressing things. Subsequent to that, my report was leaked to the press, to the Sunday Times. I don't know who leaked it, and of course, at the beginning, I was very concerned about this. But actually, in the end, I think it was a very good thing. It was handled in a very good way by the Sunday Times, Andrew Gilligan, who looked into many issues of great public concern. So in the end, although I was horrified at the time, it was a very good thing. Once it came into the press, then the trust had to say something, and they said some very defamatory things about me. They said that I didn't have the qualifications to write this review. They also said that the cases were made up. They were hypothetical. I complained about that. So that then they said they weren't hypothetical, but they weren't representative. But of course, that's meaningless. If you had an operating theatre in which a nurse raised a problem about some of the children going through theatre getting the wrong treatment, you wouldn't say, well, it's only 2 children, so it doesn't matter. It's not representative. So, and it was this way of dealing with me that led Marcus to feel that his position was no longer tenable. So he resigned from the governors. And of course, I think he made it very clear why he was resigning, and that was because the issues that I had raised were not being taken seriously, and also he was concerned that I was being publicly undermined by the trust. And of course, there's no point in resigning quietly, is there? What's the point in that? So obviously the press wanted to know, and he told them his story. And I've been involved ever since.
Wow. I remember, I know where you're at. I remember when Andrew Gilligan was releasing those articles in the Sunday Times, and every Sunday I'd be kind of like, what's coming out now? And it was around about, if I'm right, February, March, April 2019 or so, that these articles, like I think 35 clinicians were judged to have left or something.
So the service had the biggest turnover of any service within the trust. Eventually, all the child psychotherapists left. And there was a huge one of the reasons there was such a huge turnover was one, because their work wasn't manageable. So anyone could see that they were dealing with difficult children, and there was no model, but trying to, deal with this number of kids was not clinically appropriate. But the other reason was that many of these young psychologists applied for a job. As far as they were concerned, they were applying for a job at the Tavistock. So they thought this was psychoanalytic psychotherapy and family therapy. And then once they got to GIDS, they saw there was none of this. Because the then director had said to me, which I reported in my report, that it wasn't a clinical service. So I asked her what that meant. How could it not be a clinical service? So what she meant was it was an assessment service. But my view is you cannot assess an individual without getting clinically involved. So they left because it wasn't what they'd come to do, but also because the workload was just unmanageable. And for some of them, it didn't make sense. And for some of them, of course, they were very concerned about the inappropriate way these children were being treated.
And then the following, like a few months, maybe that following November, Ciara Bell, if I'm right, would have taken her judicial review of that.
Yeah.
So, Andrew Gilligan was letting out the articles. Everybody was kind of, what is going on? Somebody like me who was very much following, and Sasha, we were like, what is going actually on? Because it's the biggest, am I right? It's the biggest gender service in the world for children. As far as I know, it is. Anyway.
Yes, I think it must be.
Yeah. And then Ciara Bell, that case started. Were you there when that happened, and how did that land?
I can't remember. I retired in 2021.
Okay, so you were there.
January.
Yeah, because it was November 2019 or December 2019 that Ciara Bell took the case.
I was there. I was no longer involved as a governor. It was just Ciara Bell and an anonymous parent.
That's right.
There were 2 people. The judicial review, and just maybe to explain it, a judicial review is a particular form of inquiry. Ciara Bell was not raising her own case about medical, to say she'd been badly treated or anything like that.
Right.
What she was raising was a very specific issue that she didn't think that children and young people had the capacity to consent. Yes, I was there because I couldn't participate in the judicial review because I was an employee of the trust. I did participate in the in some of the subsequent legal proceedings after I'd left the trust.
Mm-hmm.
So, yes, then there was the judicial review, which found that children weren't able to consent. And, of course, that was a very serious blow to the GIDS service and to the trust. The trust appealed that, and they won their appeal.
And did many people come to you at that point saying, actually, David, you were right, or did many people come over, within the trust? I would have thought people started thinking, which side am I on here?
Well, I think the most important person was Sonia Appleby, who had to be cautious, but I knew that she had the same concerns all along. Secondly,
she's the child, just for everybody else, she's the child safeguarding leader. Is that what she was?
She's safeguarding child lead for the trust. And as you know, she later took an action against the trust because she suffered, can't think of the right word. She suffered...
she was kind of sidelined, I gather.
Intimidation. She was intimidated because of concerns that she'd raised. But then there were the people, I would say the people in the traditional Tavistock, so that would be like the adult department and the Portman Clinic. The Portman Clinic deals with people who have committed, often serious criminal offences, and some people suffering from quite serious, sexual problems. So the Portman Clinic and the adult and my colleague, most of my colleagues in the adult department supported my position. And some, would come to me and say so. Some wrote letters a letter in my support. But many of them, I thought, didn't want to go further than that. They had many years to go. They weren't near retirement as I was. And, so they supported me in what ways they felt able to. And I was very grateful for that. It meant a lot to me.
So then the next, I think, big thing was the CAS review, which of course came after the Kira Bell ruling, after the appeal. Can you just fill us in about the CAS review and kind of course, the Tavistock is going to be shut down. The GIDS service is going to be shut down. So just help us understand that, and what do you think the implications are there?
Well, obviously, I was very pleased that, I think my report is the publicity, and then various other organizations and groups of people raising concerns. So it sort of was a gathering storm, if you like, about what was going on in the service. Mm-hmm. And this came to the attention of, obviously, of the NHS, but also higher than that. I think there were people, obviously, high up in the civil service and so on, who were very concerned to hear about this. So, I don't know how these things are decided, but they must be decided at quite a high level. There was a decision to have a review of the service. And it took a while to appoint someone. And I was very pleased with who they appointed, because I thought Hilary Cass Dame Hilary Cass, who was a former president of the Royal College of Pediatrics and Child Health. We really couldn't have a better person. I knew she'd be fair-minded. And also she hadn't been, I think, that involved with all this before. So she brought a fresh mind to it as well. So she carried out what has been the largest review of gender services worldwide. I don't think there's been anything approaching this. She took, I've lost track, but probably a couple of years. And she's still working on it. She's only produced so far her interim report. One of the things that the clinicians had said to me, was that, and in fact, the director of the service said the same. The clinicians complained to me that some of the cases were treated as if some of these children with complex problems were treated as if they were, in inverted commas, a straightforward case.
Mm-hmm.
Well, I've been a psychiatrist for a very, very long time. And I don't know of anything that I would call a straightforward case of anything. There is no such thing as a straightforward case.
Yeah.
But they were worried about this term. And then when I spoke to the director at the time, Polly Carmichael, she said there were straightforward cases. I said, how can there be a straightforward case of a child who's in this terrible state of conflict about who they are? How can that ever be straightforward? So I think the CAS report, the interim report, has put an end to that kind of thinking, that there could ever be such a thing as a straightforward case. And I haven't looked at the Cass review before this interview. So it might be that I don't get this completely right, the way things are worded and so on. But I think in the main, it's very clear that the findings of the Cass interim review support the serious concerns that were brought to me by the clinicians and the concerns I expressed in my report. That is, that the affirmation model was the wrong model, that no child should be affirmed. We don't, as clinicians, if someone comes with anorexia, we don't affirm what they say about their weight. And interestingly, I was talking to someone from the LGB Alliance the other day, and I was saying, but maybe you would affirm, say a young adolescent who said they were gay. He said, absolutely not. Why would I do that? He said, they're young. If they say they're gay, I don't even know what they mean. They're developing. Mm-hmm. Maybe they're going to become a gay man or gay woman, but I wouldn't say, oh, yes, or that's good. I just say it's interesting that you feel that. Let's see what rolls out or what you're feeling or thinking. So this idea of affirming is a good example of how an ideological movement completely contaminated the capacity to think. So Cass has put an end to that these children must not be affirmed. Secondly, she's agreed that the evidence for puberty blockers, and we already knew this from things that have gone up on the NHS website, that there's virtually no evidence that they're of clinical benefit. There's now some evidence that they may be harmful, but also there's considerable concern that we don't know what happens to children who take puberty blockers. Because the way I would put it, Cass doesn't say this, but I think she would agree, that young people are not video machines that you can just press pause and then start again. It doesn't work like that. A child, say at the age of 11 or 12, whatever, their physiology, their neurophysiology, their psychology, and their social being is all ready for puberty. So you can't just put pause and then say you can have puberty in 3 years' time. It doesn't work like that. So also there is great concern about the effects on bone density and also effects on brain and cognitive function. And all these flagged up concerns, which have been, one of them came from the one of the national leaders on clinical evidence. But these never seem to sort of filter through. So again, Cass has underlined that there are reasons to be concerned about puberty blockers. And I think the impression I get from her report is that they should be very, very, very rarely used, if at all. But the other thing we also know, and this is prior to the report about puberty blockers, is that when they were started, the minority of children persisted. Most came off them. But currently, as it was then, 98% of children who went on puberty blockers stayed on them. So going on puberty blockers was not just an interim, even though that's the wrong kind of thinking, but it was putting them on the pathway to opposite sex hormones and surgery. So the ethical weight on that juncture is huge because of the implications. And I think Cass is very well, aware of that. Also, she's made it very clear that these children, and I'm using my words, but I think it's more or less what she says, have a kind of right to be treated as any other child with psychological problems. That is, to be treated holistically in terms of who they are, any other problems they have, their other psychological problems, their family, their social context, and so on. Where she felt at GIDS, all this was shorn off. Because the problem was, if you have a national service, if a child has multiple problems, which many of these children have, and they get sent to a gender service, that act badges them now as a gender problem. Then the service addresses a thing called a gender problem instead of just addressing a child who has difficulties. And that already sets the pathway. So one of the judges in the judicial review said rightly that one of the reasons so many children stay on puberty blockers is because once you're on them, it's already becomes a self-fulfilling prophecy. And as one, person put it to me, I think very well, that if you're terrified of puberty, which these kids are, and you think it's becoming, for example, a woman is a disgusting, horrible, terrible thing, which is what you might feel, that idea of breasts or periods or so on, and someone says we can stop that, that clinician is colluding with the disgust. And also, once you're on them, the more longer you're on them, the more terrified you are, because the whole system is supporting the idea that puberty is a bad thing, that you can't be helped.
It's a big avoidance strategy that the clinician is colluding with.
Exactly. But one mustn't think that, you have to remember that these children are in terrible pain and they need very, very careful help. So Cass has also supported the view that these children have multiple difficulties and must be looked after in a service in which all those difficulties can be addressed and not just seen through the crystal of it all being a gender issue. And the GIDS service did not have the capacity to do that. Lastly, Cass thinks a national service for gender issues is not the right model, which is certainly what I thought, that there shouldn't be a national service for gender issues. That was a very, very big mistake. And one of the problems is that mental health services in the UK are in a very, very poor shape because of year on year cutting in resources. It's all part of a bigger agenda of neoliberalism and so on, and the cutting back of state resources. Child and adolescent mental health even more so, and even before COVID, child and adolescent mental health services were on their knees. So when they saw children who had multiple difficult problems, if the child said anything about gender, they would think, oh, good, we can send them to the Tavistock. Thinking, well, we're sending them to a national service, not only about gender, but one of the leading psychotherapy services, the leading psychotherapy service in the country. Thinking they were sending them to the Tavistock, but they weren't. They were sending them to GIDS, where they wouldn't get any exploration of these other problems, and they certainly wouldn't get psychotherapy. But they were pleased because they couldn't manage these children. So if we're going to provide services for these children to be looked after in a holistic way, we will need massive resources to do so. You can't just expect CAMS, that's Child and Adolescent Mental Health Services, to do this because they're already under huge strain. I need to go fairly soon.
I want to ask you before you go, if you don't mind, just something you said earlier on, and thank you so much for speaking, about affirming the child. I often think the child wants to be, let's say the 10-year-old girl wants to be a 10-year-old boy, and she hasn't conceptualized what it is to be a 25-year-old man or a 35-year-old man or a 45-year-old man. And so affirming is affirming something for the future. When you're affirming in the present, it's a kind of a very dangerous thing to do. And it brings me to the point of...
Well, does it?
Yeah. Well, it brings me to the point, just to finish, and then...
It doesn't make sense.
It doesn't make sense, yeah. But calling them a trans kid, to me, is beckoning them into an adult concept, because it's actually only in adulthood that they will be able to transition as such, and if they can transition. And so it's kind of bringing them and solidifying a concept in their head that I think is bringing an adult concept onto a child's shoulders.
Well, I absolutely agree with you. Now, obviously, I've talked to a lot of clinicians, and I have now seen some people, adults who have gone through the service, but I'm not directly been involved in seeing children and adolescents. But my impression is that a lot of these kids, they're not really saying, if we take the girls, because it's now 70% the service was girls. And that was another concern that people had, that there wasn't a sufficient interest in inquiring why there'd been this huge explosion, and also why it had moved from being marginally more boys to now being this huge preponderance of girls. And, that's another subject which, I've talked about elsewhere, because I think it's partly to do with a kind of growing misogyny and which gets into young girls. But I won't go there now. But what you say is very, very important, because these girls don't say, I want to be a boy. They say either I am a boy, but what they say at another level is, I want to get out of this body.
Yes.
I can't stand
yes.
it. I want out, and I want now, and I want it out immediately. I can't bear it a moment longer.
Mm-hmm.
Say to such a child, well, what do you think it will be like not to be able to have an orgasm? They will say, I can't bear to think about it. They'll scream, don't use that word.
Mm-hmm.
Say to the child, what do you think it will be like never to have babies? They'll react again with disgust because they can't imagine themselves as being an older female person. So the question makes no sense. So I absolutely agree. And maybe I just want to say one thing, because it's often misunderstood that the Tavistock appealed and won the appeal. But it's very important to understand what that means. The court, this was the Supreme Court, they found that the divisional court didn't have the authority to make the judgment about this issue. That is not the same thing as saying they thought that children and adolescents could consent. It would be rather like, for example, if suppose you made a road traffic offence and a policeman wrote it down and so on, and then you complained and the court said, well, that policeman didn't have the authority to give you that offence. It wasn't his job. That doesn't mean you didn't commit the offence.
Correct.
So they weren't saying that these children can consent. They were saying, and they said in their report, they thought that very serious attention should be paid to consent. But also all the other issues that were raised in the judicial review about the poor governance of GIDS, that is the lack of follow-up, the lack of knowledge about how many had other disorders, and so on, the very poor governance. None of those were part of the appeal. The appeal was very much part of consent, narrow issue of consent, appropriately. But the other issues that were raised in the judicial review, the judge's great concern about the lack of ordinary clinical governance, they still stand.
We're really grateful for your time. We know we have to let you rush off. Thank you so much for coming on and sharing your perspective on this and all of the work you're doing around this. Thank you so much.
It's been a pleasure.
And thank you for bringing it out to the public. It was really important.
Yes. Thanks for joining us this week on Gender, A Wider Lens. This podcast is sponsored by Rhyme and GenSpect, and listener support means a lot to us. The best way to help is to subscribe and review us on iTunes.
Follow us on social media, and if you'd like to become a patron, you'll have access to weekly transcripts of the show, special Q&As, and you can join our listener community. Just go to our Linktree. That's linktr.ee/widerlenspod.
Our discussions are for educational purposes only and are not intended as a substitute for mental health services.